Alrighty, hello friends. So today I'm going to do your last review for your exam tomorrow. I apologize that I'm getting this up a little bit later than I wanted to. I was gonna try to get it up last night and that wasn't gonna happen. So I apologize, but hopefully you've been watching the cancer reviews that I posted. And then this HIV one will kind of just be like a nice summary of what you've hopefully already been studying. I will say, and obviously, don't quote me on this, and every exam has the potential to be different, but I feel like HIV, there was not as much when compared to cancer and stuff. So, yeah, so I don't know. That's really all I have to say about that. Okay, so as always, leave your emails and let me know if you have any questions. Okay, so HIV, we've all heard of HIV AIDS, how popular it is and how chronic it is. So HIV is a retrovirus that suppresses immune function and leads to AIDS. So, like I said, very chronic disease. We've heard a lot about it. It was identified in 1981, and then we had the epidemic in the 70s. So first thing I have here is largest population are men having sex with men. So that's about 42 to 46% of cases. And then most newer cases, I guess, are women, people of color, those in poverty, and adolescents, with other cases related to those with drugs and a lack of access to healthcare. But men having sex with men is the biggest population that is affected. So, going off of that, heterosexual women now represent the fastest growing group of HIV affected people, which I thought was kind of interesting. Elderly is another large growth area that we're seeing, with 15% of new cases being over the age of 50, or 50% of cases being over the age of 50. One thing I remember Schneider talking about with this, though, is how this doesn't necessarily mean that new cases are popping up in those over 50. It just means people might be living longer with the disease, which is obviously a good thing. But I would say, related to populations affected, just know that the largest population is men having sex with men, and then most cases are related to women, people of color, those in poverty, and adolescents, along with drugs and lack of access to healthcare. And then know that heterosexual women represent the fastest growing group of HIV affected people. Alrighty. So as far as the epidemiology behind HIV, so HIV is bloodborne and it's transmitted through semen, vaginal secretions, and breast milk. So, so HIV is not generally in urine, saliva, emesis, or sweat. So that's very important. I know we had to select all that was about all the different body fluids, and it was select the ones that HIV can transmit through or something like that. So just know that it can transport through blood, breast milk, semen, and vaginal secretions. Those are the main four. And then it's not spread through urine, saliva, emesis, or sweat. So that's sorry, my notes are all over. Okay, so as far as transmission goes, a little more about that. So HIV is a really fragile virus, so it cannot survive long outside of the body, unlike, other viruses like hepatitis, which can live for days. Survival time of HIV, sorry, my voice is kind of gone, so just ignore that. So survival time depends on the size of the liquid, droplet, and it depends on how much of fluid is present, and also what kind of fluid it is. Like I said, 4 fluids, I'm going to say it again because I know you're going to have a question on it. Blood, semen, vaginal fluid, and breast milk. Those are all like the 4 sources. Um, and like, even though HIV has been isolated from pretty much like all body fluid and tissue, that doesn't mean that they're all like responsible for transmission, if that makes sense. So just know those 4 and you'll be golden. So then sexual contact is the most common mode of transmission. I would also know that. Blood products can also transmit the virus through like needles and syringes. And then about 25% of mother to fetus if mother is not on treatment, while 2% if mother is on treatment. Okay, I remember we had a question on this. And like, I want to say that we actually had a question on like the numbers with this. So usually, Schneider doesn't test over like what percentage of blah, blah, blah. But this is very important to know. So understand that 25% of transmission from mother to, there's like a 25% risk chance of transmission from mother to fetus if the mother is HIV positive, if the mother is not on treatment. However, if the mom is on treatment, there's only like a 2% chance of transmission from mom to fetus. So just understand that like if a mom is pregnant and she's HIV positive and she is getting treatment, then like there's actually a really low risk that she's going to transmit the virus to her baby, which I thought was pretty interesting. So I would definitely understand that. But that's like pretty much everything with epidemiology, pretty straightforward. Also, HIV is an RNA virus, so it can replicate going backwards. So it goes from RNA to DNA. It needs to be inside a living cell to replicate. As far as the target cells for the HIV virus, so CD4 and T cells, so lymphocytes, are the target cells. And so what happens is once the HIV virus is inside a CD4 cell, this like triggers transverse transcriptase, which turns the RNA virus into DNA and copies itself. And so this is important to know because usually meds are reverse transcript. Why can't I say that? Meds are usually reverse transcriptase inhibitors. So that means that they prevent this turning of like RNA into DNA. Protease is another enzyme in the process. And so sometimes we also have medications that try to target this and will try to like inhibit the replication. So just a little bit of like microbio for you. All right, so moving on from like epidemiology. I feel like I kind of went all over with that, so my bad. But like I said, just understand like men having sex with men is like the largest population, sexual contact, most common mode, but it can also be through blood products, semen, vaginal secretions, and breast milk. Understand the whole like risk and how it decreases with like pregnant women to their fetus if they're on treatment. So yeah. Okay, so as far as clinical manifestations, hold on. Yeah. Okay. So clinical manifestations of HIV are actually like primarily from opportunistic infections that happen as a result of HIV. So, like I said, HIV suppresses the immune system, so it makes you a lot more susceptible to infection. And so like your actual symptoms don't necessarily come from the HIV virus itself. They come from the infections that you get from having the HIV virus, if that makes sense. Hopefully that's not like confusing. So there's a couple different stages. So this is really important to know. I definitely understand this. So we first have the acute infection. So this happens from like 2 weeks to 3 months, and there's a really high viral load due to rapid replication. So your CD4 count is around like 800 to 1200. So you want to monitor immune function because this is like a normal count. And so like your signs and symptoms here, this is really important, are flu-like. So you might have like Swollen lymph nodes, I have that highlighted, like fever, headache, malaise, just general symptoms that you would have with the flu. And it usually takes about 3 months for antibodies to be detectable in the body by a test. And so, like, it's important to know that if you test somebody, like, during the acute infection stage at like 2 weeks, they're not necessarily going to have a positive, because it can take like 3 months for you to be able to tell the that like the virus is in the body. So then when you go from the acute infection, you go to chronic infection. And so you have 2 stages with that. You have the asymptomatic infection and the symptomatic infection. So the asymptomatic infection is when the CD4 count is more than 500. So this is like fatigue, headache, low-grade fever, and night sweats. And then symptomatic infection is when the CD4 count is 200 to 500. And so the body really just like cannot keep up with this virus that is targeting the CD4 cells. And so your symptoms are just going to get like more fatigue, like more frequent and more like chronic. So you're going to have a persistent fever, night sweats, chronic diarrhea, fatigue, things like that. So then after symptomatic, we move to AIDS. And so the definition of AIDS is when you have a CD4 count less than 200, and this is obviously like the most serious stage. And so this is when you're really immunocompromised, you have muscle wasting, malignancies, and you're just really, really at risk for those infections, and probably like dealing with an infection of some sort, like already. So those are like the 4 stages, I guess, right? 4, yeah, acute infection, chronic asymptomatic, chronic symptomatic, and then AIDS. So with all 4 of those, I would understand the CD4 count. Very important to know that. Maybe had a question on that. So like I said, acute is 800 to 1200, asymptomatic chronic is more than 500, symptomatic chronic is 200 to 500, and AIDS is less than 200. I would understand that like acute infection is just general flu-like symptoms, chronic asymptomatic is like those same symptoms, symptomatic is persistent flu-like symptoms, and then AIDS is like obviously the most serious, so you're immunocompromised, muscle wasting, that sort of thing. Okay. So another thing about symptoms I have can last for a few days. Yeah, okay, so I have another thing on symptoms really quickly, which I don't know. I just remember when we learned this, I kind of thought this whole process was a little confusing, but I have noted that signs and symptoms can last from a few days up to a few months in HIV patients, but it's usually like 14 days. So they might be in a stage and not like showing symptoms the entire time, but that doesn't mean that the virus is gone. Okay, next, talking about just kind of like the timeline of HIV and these like symptomatic or these phases. So the timeline if HIV is left untreated. So an acute infection, I think I mentioned this, can last like 1 to 3 weeks. And then like I said, I have this bolded, so I would really understand this. So it can take 3 to 12 weeks for HIV antibody tests to come back positive after an immune response. And so we had a question on this, and I'm pretty sure this was like the exact question. I don't know why I have this. Maybe our peer leader told us, but so if you have a patient that had known exposure to HIV and they come in 3 days later and get a test and it's negative, you tell them to come back for testing later, because this doesn't mean that they're HIV negative. Like, it just means they don't have any antibodies. So you would need to wait at least 3 weeks before you test them again, because like I said, it can take 3 to 12 weeks for the antibodies to actually be present. So that is very important to understand. And a lot of times it takes, like on the longer side, it can take like 3 months. But very important, probably gonna have a question on that. So then your chronic infection, it can begin after like 7 to 9 years, and then it can take like 10 to 12 years for AIDS to develop. And so that's kind of just like the generic timeline. And the lifespan, if someone is not treated at all, is about 11 years. So diagnostic-wise, it's first off really important to understand that during the initial 2 months that a patient has the HIV virus, they are severely infected and they have a super high viral load. And so the virus is basically going crazy and they're massive shedders of the virus. And so like that's very important to understand. And so these diagnostic tests like are all linked to antibodies that mostly form 3 weeks to 3 months, like I've said, after you're infected, but it can take as long as 6 months. And so one thing with HIV is that you can be asymptomatic for many years and then just like all of a sudden start showing symptoms, and you could have had the infection for like 10 years at that point, which is kind of crazy. Like you could be infected for 10 years and have no idea and then start showing symptoms one day. So that's why like understanding the risks and knowing kind of like how HIV spreads so you can detect if you were exposed is important. So we can do rapid testing at home, but with saliva, but it needs to be confirmed. So very important to understand that if you have a patient that does a rapid test at home, that you need to educate them that they should go get confirmed with like a standard HIV test. Going back to that viral load, just a little bit more about that. So viral load is a measure of the number of copies of the virus that can be detected in a patient's serum. And so viral load and then CD4 count, because remember CD4 cells are the cells that HIV virus targets. So viral load and CD4 count are used to monitor the progression of the disease and symptom management and like how effective treatment is. So a viral load greater than 55,000 and a CD4 count of less than 200 have an 85% chance of progressing to AIDS within 3 years. I don't know why, but I have that highlighted. So, like I said, viral load, measure of the number of copies of the virus that is detected in a patient's serum. There's a couple different tests that we can do. So like I said, we have the rapid HIV test that a patient can do at home with saliva, but they need to go and get a standard test if they get that, just to like confirm the negative or the positive. The ELISA, which is enzyme-linked immunosorbent assay. So that's usually a follow-up test. But if this comes up positive, then you want to move your patients onto the Western blot, which the Western blot is even more sensitive for HIV antibodies, and it's more of a confirmatory test with almost no risk for a false negative. So this helps you to know kind of like, I guess it's because it's not as like prone to having a false negative, this is going to be more helpful for understanding if your patients have HIV. This can also help you to understand what type of HIV, because there's different types. So type 1 is the main kind in the US, and it's easier to treat. And then there's also like drug-resistant strains, and so that can happen if you don't stick to your regimen or to like your medication. So those are the tests I have. So the thing I would understand is like what a viral load is, and understand that viral load and CD4 count are used to monitor progression. Understand the rapid HIV test and how you can do that at home with saliva, but it needs to be confirmed with another test. ELISA, but if this is very important, I think we had a question. So if your ELISA test comes back positive, then move on to the Western blot, because the Western blot is even more sensitive for HIV antibodies. This next thing I'm about to talk about is very important, and I'm pretty sure you'll have a question like pertaining to this at some point. So it's very important to understand that when there are fewer than 50 viral particles per milliliter in the blood, when you test a patient for HIV, they are virally suppressed and undetectable. And so undetectable means untransmittable. So if you're undetectable, you can protect your own health and you prevent like other new HIV infections because you can't spread it. And so like this doesn't mean that you don't have HIV anymore, because you do. It just means that like by continuing your treatment, you can live with HIV by managing your health and preventing the spread for new infections. On the other hand, though, when there's higher than 1,000 viral particles per milliliter in the blood, HIV is reproducing and further investigation is needed, because this probably means that a patient is not entirely compliant with their medications. You might need to change their medications. Can they even pay for their medications? Like, what is going on that is causing this viral load to be so high? So very important to know that undetectable means untransmittable, and that's when it's lower than 50. And then if it's above 1,000, you're going to want to investigate like why it's above 1,000, understand that. It's so hard. I feel like I say like we had a question on everything, but like, I don't know. I don't always remember, but I do think we had some sort of question, and it was like, your patient's viral load comes back at 1,000, like what are you going to do? And it's basically you just want to find out more about like what kind of medication they're taking, how often are they taking it, are they actually following their treatment, like that sort of thing. So now we're going to move into pharmacology, everyone's favorite topic. So pharmacology, so we use antiretroviral drug therapy, or ART, which is up to a 3-drug combo, and it has the goal of maximally suppressing a viral load to preserve a patient's immune system and improve their quality of life and reduce mortality. So there's lots of medications that are possible. Important to know, these meds have terrible side effects, and drug toxicity is actually really, really common. There's also HAART, HAART, which is highly active antiretroviral drug therapy. And that's like a protease inhibitor combination with 2 other drugs that are usually the reverse transcriptase inhibitors. So with pharmacology, we have the meds that you take, it depends on if you're like in post-exposure prophylaxis or if you're in pre-exposure. So post-exposure prophylaxis. So the risk of being infected with HIV after exposure to body fluids from a positive patient is actually really low for occupationally acquired HIV. So that's like for nurses, if we're exposed to the body fluid of an HIV positive patient, our risk of developing that infection is actually low. The highest risk, though, would be through percutaneous exposure. So that would be like needles. And there's actually no cases reported recently after skin-to-skin exposure. So like I said, healthcare-associated exposure through needle sticks is the highest risk. And so just understand kind of like needle safety, don't reuse needles, don't recap sharps, those sort of things. And obviously, like, we're going to test nurses and stuff if we think that there's like a really big risk. So the pre-exposure prophylaxis is called PrEP. I'm sure Schneider talked about this a lot. He talked about it with us for a good chunk of time. But this is for uninfected people that want to lower their risk of transmission. And so basically this could be for patients that are at high risk or like don't consistently use condoms, they have a positive partner, they have an STI within the last 12, have an STI, multiple partners, sex with men, transgender sex, people who trade sex for money or drugs, women who had sex with a male, you use needles for drugs, etc. So basically just what all that means in a nutshell is a patient who's high risk, you can use PrEP just to kind of help like lower that risk of developing the infection. So what PrEP is, so it is, I cannot ever say this. So it's Truvada, that's the name, but it's it's Truvada. Just know it's Truvada. But it's really important to understand that you need to have like a daily regimen and adherence. So like patients have to take this every day. And if they don't take it every day, then it's not going to work. This is also not an effective treatment of HIV. Very, very important to understand that PrEP is not treating HIV. So before that you would ever start a patient on these drugs, you want to make sure that they're negative for HIV, because obviously if they're positive, we don't want to give them PrEP because it's not going to do anything. And so like I said, it's 1 pill a day with or without food, and this keeps a patient's serum from converting. You still want to do follow-up testing just to make sure, and then they're still recommended to like follow safe sex practices, so use a condom, treat any STIs that you have, try not to have more than one partner, make sure you know your partners, and then also like don't trade sex for money, drugs, don't use needles for drugs, but obviously if like someone's going to still engage in any of those behaviors, like being on PrEP is very helpful to them. So yeah, that's all I have medication wise. So now we're moving into a couple of like the side effects, but some of the effects from HIV that we as nurses need to understand. So like I said, biggest thing that HIV patients have is risk for infection. And so opportunistic infections occur when the CD4 count falls below 200. So remember, that's when they're in that classified AIDS stage. And that's a major, major complication of HIV disease. And so one thing is like, you want to educate your patients on infection prevention. So this would be like decreased risky behavior and exposure. Antioxidants like vitamin C and E can reduce oral infections and diarrhea. You want to treat specific infections and have supportive care when needed. Bacterial infections, there's a couple here. So Mycobacterium avium complex, or MAC. So I have this highlighted. This is the most common infection with HIV and AIDS, and it affects about 50%. It presents itself with diarrhea, gastroenteritis, and weight loss, and you diagnose it with a blood culture. And usually it only takes one blood culture because the count is so high. Bacterial infections can also present themselves with the TB like pulmonary process. So just think back to like TB symptoms. So like high fever, night sweats, fatigue, weight loss and anorexia, that sort of thing. And we diagnose that with a sputum specimen or bronchial washing for the Mycobacterium tuberculosis. So that's the TB like pulmonary process. Pulmonary infections usually present with hypoxia, non-productive cough, and fever. I have that highlighted. And then just understand that like there's lots of different meds and like antibiotics that you can use to treat these bacterial infections, but like rifampin, Cipro, like those are some of the more common ones. Next, we have fungal infections, so candidiasis, or a yeast infection. So thrush is in the mouth, and it's indicated by a white coating on the tongue or oral membranes. You could have ulceration, but it's not required, and it's usually very painful, and they bleed easily. A vaginal yeast infection is creamy white with lots of burning and itching. This obviously infects the GI and GU system, and usually doesn't affect people until they're immunocompromised. So nursing education for somebody that has a yeast infection. So know that they can't usually tolerate temperature extremes, spicy foods, and then soft foods are better, and they should use soft bristles for oral care. So that's obviously talking about thrush. Cryptococcus is the next one for fungal, and this is primarily affects the central nervous system. It can be fatal, and then it can also affect the lungs, but it can be asymptomatic. So if it affects the central nervous system, it can be fatal, whereas when it affects the lungs, it's usually asymptomatic. It can also affect like the skin, bones, liver, kidneys, other areas. This is found in pigeon droppings and remains viable for up to 2 years. It's usually aerosolized and inhaled, and you would use diflucan and amphotericin B to treat it. Probably not saying any of that right. Next, I have histoplasmosis for fungal. So that's from chicken coops, kicking up dust, working with surface soil, remodeling old houses, demolishing and exploring caves, primarily in the lungs, and once again, diflucan, myostatin, and amphotericin B. I would understand that those meds are used for fungal. Next, we have protozoal infections. So Cryptosporidium commonly affects the intestines, so you could have like electrolyte imbalances, fever, nausea, vomiting, diarrhea, GI symptoms, and the patient will need IV fluid replacement. Next is pneumocystitis carinae, PCP. This is the primary cause of pneumonia. I have that highlighted. So just look at symptoms like dyspnea, non-productive cough, fatigue, tachypnea. You might have crackles, decreased breath sounds, cyanosis. And then Toxoplasma gondii is most commonly caused by ingesting infected foods like raw meat and vegetables, and is a major cause of encephalitis. And then finally, I have viral infections. So we have cytomegalovirus. If systemic, this causes inflammatory reactions in the lungs, GI, liver, pretty much everywhere. And it's a major, major cause of blindness in those with HIV. So I would remember cytomegalovirus is associated with blindness. Herpes simplex virus is, remember those like painful lesions like on the skin, mucous membranes, a lot of times around the mouth. And if it's systemic, it can affect the brain. So you would treat that with acyclovir. And viral infections are transmitted through like breast milk, saliva, cervical secretions, semen, feces, urine, and blood. I know that was a lot, going through all those viral infections, protozoal, fungal, and bacterial. I honestly don't even remember there being much about this. I remember I would understand that Mycobacterium avium complex is the most common infection with HIV and AIDS, and remember that's the bacterial infection. There's a TB pulmonary process, so pulmonary infections are usually with that hypoxia, non-productive cough, and fever. I would understand the nursing interventions for if someone has a candidiasis, so thrush in their mouth. And then I would understand the primary cause of pneumonia is that pneumocystitis. That's the protozoal. Cytomegalovirus is major cause of blindness. Oh, and then also I have HIV-related cancer, which is the Kaposi sarcoma, which is like the dark blue, purple, or red papules. So you would see those on the body, and we treat that with surgical removal. And if it's systemic, we use chemo or radiation. I think we had a question on that. I think he showed us a picture of somebody that had those papules and was like, what is this? So I would just know that that's Kaposi sarcoma. So that's all I have on infections. I would also just remember your infection prevention, just basic infection prevention. Another thing that can happen with HIV patients is imbalanced nutrition because of the medication therapy, the symptoms, all of that. And so with HIV patients, we don't recommend a particular diet, but we try to get them to have high calorie and protein meals, 6 small meals a day rather than 3 large ones. We make sure that they are cooking their food well because remember, they're very at risk for infection. And so we don't want them to get infection from poorly cooked food. And then we also want to encourage them to exclude dairy products if necessary because of that same reason. One thing that can happen is wasting syndrome. So this is also known as cachexia, and it's involuntary weight loss that exceeds 10 to 15% of your baseline weight. And so this is related to just that decreased nutrient intake, decreased nutrient absorption, and just overall disturbed metabolic balances. This isn't uncommon with art therapy. So I would just know the education that you would give your patients for this. So If they have nausea and vomiting, they need to eat toast or dry crackers and drink beverages 30 minutes before their meals because that can help decrease nausea. And then also they can use like antiemetics, marijuana, or acupuncture. Other things to educate regarding like nutrition would be like to do to eat with others, just to like help them just to help encourage them to eat. So have them eat with others, take their meals into a pleasant surroundings, once again encourage nutrition, mouth care before meals, sitting up in a chair for meals, and then also we worry about obesity and poor nutrition due to the cost and availability of health food options. So like these therapies that patients are getting with HIV might be really expensive depending on their coverage, and so like they might be more opted to go to like fast food restaurants and get chips and stuff, and so we want to watch for that, not just anorexia. That's what I have for that. And then some miscellaneous things I have on HIV and AIDS. So there's no cure yet, obviously, so we're focusing on coping, and there's also no vaccine. Healthcare personnel risks are related to exposure. We also talked about that. It's also our duty as nurses to warn, and so there's like criminalization for people that knowingly transmit HIV. So like if you have HIV or you have a risk, like you obviously have to tell people. And finally, and then there's also lots of local resources that you can get. Last couple things that I have under miscellaneous, going back to that heart therapy, so the highly active antiretroviral therapy. So these meds are causing patients to live longer, and they have less side effects and are tolerated a lot better than the ART therapy, which is the antiretroviral therapy. I don't know if I said that or not, so I just wanted to say that. And then also, how could I forget this? This was a question that almost got me. So understand that your precautions for HIV positive patients are standard. So remember, your standard precautions are just like wearing gloves into a room. You don't have to wear goggles, don't have to wear a mask, all those things. And the only reason, well, in COVID times, we're obviously wearing a mask, but the only time that it wouldn't be standard is if you were like around secretions and you like knew that they were going to be like splashing in your face. But other than that, just understand that you only need gloves for patients with HIV. That is very important. You will definitely have a question on it. Let me see if there's any other miscellaneous things here. Gay and bisexual men of all races are the most severely affected. I think I mentioned that. Yeah, that is like all I have. So yeah, I don't know what else to say about it. Okay, like I said, sorry that I'm getting this up later. I'm around for questions though. I am driving back to St. Louis later this afternoon, so I will be unavailable for a couple hours, but then I can answer your questions however you want. I wish you guys the best of luck. Like I said, this exam I feel like was definitely the easiest for my cohort, so try not to like stress yourselves out. You guys have this exam and then one more and then you're done. You guys are almost term 5, which is probably really crazy, but like I said, any questions, let me know. Otherwise, have a great day, guys, and happy studying.